thanks very much for the invitation to speak at The Limits. I'd like to talk to you today about the role of autoimmune kidney disease and inflammation in the kidney on cardiovascular disease, and specifically focusing on the role of therapies. Observational studies have for a number of years shown us that there is an increased risk of cardiovascular disease in patients who have underlying autoimmune or inflammatory conditions. This study from a number of years ago looked at just under 500 women with lupus and compared them to matched control population from the Framingham Offspring study, and showed a significantly increased risk of cardiovascular events, specifically acute myocardial infarctions and angina in those patients with lupus, especially in the younger age groups where we would normally expect there to be a degree of protection in young women. Of those patients who were studied with coronary angiograms or on autopsy, a significant proportion of them actually had coronary atheroma. Looking specifically at the age groups that were affected, we can see that there's a 52-fold increase in one age bracket between 35 and 44 of the patients with lupus compared to the control population. And the risk factors for developing cardiovascular problems were older age at lupus diagnosis, 39 years compared to 34 years, hypercholesterolemia, longer diagnosis of lupus and longer steroid treatment for the lupus, all being postmenopausal. Similar studies such as those in ANCA-associated vasculitis showed an increased mortality compared to the normal population. And whereas in the first year the mortality was mostly due to infection or to underlying active inflammation, the vasculitis itself, beyond the first year mortality was really predominated by cardiovascular events. And the risk factors in this population were younger age, worse kidney function, and higher disease activity as measured by the BVAS, as well as a number of other demographic factors. So specifically focusing on lupus and vasculitis in patients who have kidney involvement, we find somewhere between 3 and 8 times more cardiovascular events compared to age and renal function matched populations. And these increases in proportions are not explained by the traditional cardiovascular risk factors. But we do understand that inflammation underlies both of these conditions. If we look at a cartoon depicting the etiology of ANCA vasculitis, and it would be fairly similar if we looked at one depicting lupus etiology, we find the neutrophil is at the center of the damage that's being inflicted on the vessel wall, neutrophils degranulating, releasing proteases and pro-inflammatory cytokines, as well as being the target of the autoimmune process themselves due to the release of proteinase 3 or myeloperoxidase, or its expression on the cell surface. We see that neutrophils also release neutrophil extracellular traps, which can then be taken up by antigen-presenting cells and presented to the immune system to provoke an ongoing inflammatory and autoimmune process. If we look at a similar picture of atheroma, we find the neutrophil degranulating, producing nets, is also in the center of this pathogenesis, stimulating macrophages to produce pro-inflammatory cytokines, which can in turn stimulate T cells, and the combination of the activated macrophages, neutrophils, and T cells can stimulate atheroma plaque progression and rupture. And this is made worse by the presence of hypercholesterolemia, as well as by a number of different factors, such as the total white cell count. So this cartoon, taken from Professor Libby's recent review, shows that neutrophil extracellular traps stimulating monocytes can produce pro-inflammatory cytokines, which then progress the development of the plaque. And the macrophage increases its pro-inflammatory cytokine production in part through activation of the inflammasome. So when we looked at human monocytes, as opposed to those data coming from mice, when we looked at human monocytes, we find that if you take unstimulated monocytes and compare them to those stimulated with cholesterol and neutrophil extracellular traps, having stimulated neutrophils, we find a significant increase in IL-6 production in these monocytes, which again would fit with a pro-atheromatous phenotype. So if we were to target inflammation by targeting the neutrophils and the monocytes and their activation, their degranulation and their net release, we should be able to not only reduce atheroma formation, but also reduce nephritis in those conditions where nephritis is a common factor. But how we do it may be critical in mediating the effect that we want, because there may be detrimental effects from the treatment that we're using. The first study to look at using anti-inflammatory therapies to treat atheroma was this one, where IL-1 beta was targeted with a monoclonal antibody, canakinumab. And this showed that using this canakinumab, there was a reduction in cardiovascular events in the patients treated compared to placebo, and there was a significant reduction in the high sensitivity CRP as a marker of inflammation in those patients that responded. There was no difference in the traditional factors such as cholesterol or triglycerides thought to be important. So targeting inflammation rather than cholesterol is a new strategy to think about atheroma. But in renal medicine, our traditional ways of targeting inflammation, specifically within the kidney, are to use steroids. And glucocorticoids form the backbone of our therapies across all the nephritides. They were isolated in the 1930s, used first in rheumatoid arthritis in the 1940s, and really since the late 1940s and 1950s were introduced for the treatment of inflammatory kidney diseases. A significant proportion of the population in hospitals in the US are prescribed steroids, and it's fair to say that in the treatment of nephritis, despite them being the backbone, we still don't really have a very good handle on how best to use them. The introduction of high-dose steroids for the treatment of nephritis dates back to the 1950s, when two retrospective studies looked at the outcome of patients with lupus nephritis treated either with low or high-dose steroids. A total number of patients treated 26, but these papers really informed how steroids were going to be used in inflammatory nephritides from that point onwards. So comparing 10 milligrams a day of prednisolone with somewhere between 40 and 60 milligrams a day for 6 months was seen to show a difference in the mortality rate in the patients treated, 10 dying on the low dose and only 7 dying on the low dose. These proportions seem slightly small to be making significant decisions about how we use steroids, but nonetheless, they had a major impact on the outcomes in the day. Subsequently, people started to use high-dose pulsed intravenous methylprednisolone, suggesting that it may be able to reduce the total amount of oral prednisolone that patients were subjected to. And then a number of years later, with the introduction of immunosuppressants such as cyclophosphamide or azathioprine, the outcomes of patients, this study looking at lupus and lupus nephritis specifically, was significantly better, but nonetheless the dose of steroids wasn't adjusted despite the fact that other agents were introduced to treat the patients. So we've still ended up with high-dose steroids, despite the fact that we now have intravenous cyclophosphamide, rituximab or azathioprine being added on for the treatment of these conditions. If we look at the steroid protocols in the treatment of ANCA-associated vasculitis, these are graphed according to the studies. The first original NIH study shown in the dotted line, and then subsequent studies that were done by the UVAS groups looking at different induction therapies in the treatment of ANCA vasculitis. The latest study, which is probably the largest, which was the PEXIVAS study, looked at high and low doses of steroids, but you can see that even the low dose of steroid had a significant steroid dose compared to what we used previously. So what about steroids and cardiovascular disease? Well, it's long been known that patients with Cushing's disease have an increased risk of atheromatous disease. This study looking at lupus and cardiovascular disease was a post-mortem study looking at 36 patients treated either for a long period of time with steroids, a short period of time with steroids, or no steroids at all, and looked at the outcomes in terms of cardiovascular disease and atheroma, and showed an increased risk of hypertension in the patients treated with steroids, increased cardiac fat deposition, and significantly more coronary atheroma in those treated with more than 1 year of treatment with steroids. And if we look at a study examining the use of steroids from a GP population, comparing patients on steroids with those who are not taking steroids for various inflammatory disorders, including ANCA vasculitis and lupus, as well as other connective tissue disorders and bowel disease. This study looked at the outcomes in terms of mortality, which was mostly due to cardiovascular disease, and showed that for every 5 milligrams a day of prednisolone use, there was a 26% increase in the mortality, or over the course of a year, for every gram of prednisolone equivalent that was used, there was a 5% increase in mortality. If we look at the impact of glomerulonephritis, the inflammatory kidney disease, on cardiovascular outcome, These are data from a kidney transplant registry looking at what kidney transplantation did to cardiovascular disease, showing that there was a 17% risk in cardiovascular disease as assessed by acute myocardial infarction compared to those patients who were not transplanted and maintained on a wait list. But the important data that came out of this was that glomerulonephritis and diabetes were the two highest risk factors for the acute myocardial infarct compared to other causes of end-stage renal disease, suggesting that inflammation is accounting for a significant proportion of the cardiovascular disease that is accrued. But there are problems with these data in terms of causality and association. So those patients who have the greatest degree of inflammation will also need the greatest quantity of steroid therapy to try and control their disease. So is it the steroids, is it the inflammation, or is it a combination of both that accounts for this increased cardiovascular morbidity and mortality? We set out to try and answer this by developing an animal model where we induced nephritis in the mice that were fed a high-fat diet and were prone to atheroma because they were ApoE deficient mice, and then studied the use of different therapies to try and understand the impact not only on the kidney disease but also on the atheroma. The graphs at the bottom show the impact of plaque area on the left, IL-6 and proteinuria from left to right, and you can see that the ApoE knockout mice given nephrotoxic nephritis had significantly more plaque than the wild-type mice with nephrotoxic nephritis, and significantly more than the ApoE knockout mice not given any kidney disease. There was a non-significant increase in IL-6, and there was no difference in the proteinuria levels between any of these mice. At the top panel, you can see that the gross lipid deposition in the aortas on the ApoE knockouts with NTN, the ApoEs with saline, and the wild-type animals across the top from left to right. If I show you the treatment with prednisolone in the bottom left-hand corner, you can see that there was a huge increase in the amount of lipid deposition in the aorta in animals treated with prednisolone. And if I show you this graphically, you can see that there is a statistical and very significant increase in the amount of plaque compared to the ApoEs with nephritis alone. So steroids do seem to be inducing more atheroma, and they also induced an increased mortality in the mice that were fed a high-fat diet and given prednisolone. And this is despite there not being any differences in the levels of LDL or blood glucose between these groups. Now, we had previously shown that rather than using steroids, if we used MPO inhibition as a therapeutic strategy, we could treat nephritis very well. So we showed that MPO was deposited in the glomeruli of animals with nephrotoxic nephritis, as well as in patients with various numbers of inflammatory kidney diseases. And if we treated animals with an inhibitor that targeted MPO and neutrophil degranulation and activation, we found a reduction in proteinuria, a reduction in plasma creatinine, and a reduction in the glomerular damage that ensued. So there are alternatives to targeting neutrophils and neutrophil extracellular trap release that do not involve using steroids. Another strategy to deal with avoiding steroids is not to use them for very long, and we have championed a strategy to use a very short course of steroids just for 2 weeks, like we do in kidney transplantation, in patients with ANCA vasculitis, and showed that over a long period of time, patients did not need the introduction of steroids for the vast majority of them, and outcomes in terms of relapse and patient survival and kidney survival were extremely good. And if we compare the steroid minimization that we introduced with what was traditionally given in ANCA vasculitis, the graph that I showed you before, you can see that the straight orange line going downwards is how much steroid exposure there is with this protocol. There may even be room for more steroid reduction. So the implications for the therapy of kidney disease and atheroma is that if we could reduce steroids, we might actually reduce the morbidity and the mortality from cardiovascular disease in this population that has a significantly increased risk. We need to define alternative strategies that can target the neutrophils and the monocyte activation that could potentially treat both the kidney and the vasculature. and moving forwards thinking about combined endpoints, not only looking at the outcome of the kidney, but also looking at longer-term cardiovascular outcomes may be very important. I'd like to thank my collaborators, but mostly I'd like to thank Marilina Antonellu, Doctor, who did all of the work, and thanks very much.